General Wakar Muzaffar Saab, who's come from Islamabad, Professor Tariq Khan Marwat, who's come from Peshawar, and I'll be moderating the session. My name is Huma Kyani. The first speaker for today is Dr. Bilal Khan, who's come from US. Sir, please come on the dais to present your presentation on epiretinal membranes, visual outcomes, and prognostic factors, an interesting case of laser-induced macular hemorrhage. Sorry, this is Usman.
Good morning. So, epiretinal membranes are contractile fibrocellular proliferation on internal limiting membrane, which can lead to distortion of the retinal architecture and underlying photoreceptors with resultant metamorphopsia and loss of vision. Overall prevalence is about 6 to 7% of the population. This does increase with age and reaching up to 15% around 80 years of age. Most of the cases of epiretinal membrane are idiopathic and surgical removal is recommended as standard therapy. However, after epiretinal membrane surgery, the time required for restoring natural retinal structure and function may be variable. And unfortunately, desired visual outcomes are not always achieved even after apparent successful removal with structural improvement. So efforts to identify reliable prognostic factors to predict postoperative visual outcomes have been ongoing. There are several clinical biomarkers which have been looked at, such as preoperative visual acuity, duration of the symptoms, age of the patient, and cause, whether it is idiopathic or secondary to conditions like diabetes, retinal detachment, inflammation, or trauma. Better preoperative visual acuity, shorter duration of symptoms, less than 6 to 12 months, younger age of the patient, and idiopathic cases are generally have better prognosis. Several OCT biomarkers as possible prognostic indicators have been looked at as well. That includes overall central foveal thickness and inner retinal biomarkers such as cystoid macular edema, stage of the epiretinal membrane, including the concept of ectopic inner foveal layers and disorganization of the inner retinal layers. Outer retinal biomarkers such as ellipsoid and interdigitation zone disruption and what is called as central bouquet abnormalities have been looked at. We will look at details of each of these in subsequent slides. Let's look at the normal anatomy of the OCT. On the left side, there is normal inner retinal layers OCT. As you can see that all the cellular layers which are marked by blue boxes are hyporeflective and all plexiform layers which are marked by red boxes are hyperreflected. Also notice that there is this inner plexiform and inner nuclear layers, they finish at the fovea. They don't cross the fovea. So in the outer retina, there are 4 distinctive hyperreflective bands which are from inside outwards are external limiting membrane, ellipsoid zone, interdigitation zone, and RPE Brooks membrane complex. Normal central foveal thickness is around 300 micron. In epiretinal membrane eyes, it can reach up to 600 micron, and increased preoperative central foveal thickness is a negative prognostic factor. Postoperative, there is usually decrease in central foveal thickness, and it usually is parallel to the visual improvement, but degree of CFT reduction does not always match the degree of vision recovery. Cystoid macular edema, which is defined as hyporeflective intraretinal cystoid spaces, either derived from fluid leakage from damaged vasculature or just the empty spaces of the stretched retinal tissue under epiretinal membrane. Several studies have looked at association of CME to ERM prognosis. Cicinelli and colleagues reported that CME in epiretinal membrane eyes was associated with more advanced ERM stage and older age. Eyes with CME had a 2-fold risk of macular edema worsening after surgery and carried a poor visual and anatomical prognosis. Cowan and group divided epiretinal membranes into 3 groups based on presence or absence of interretinal cystoid spaces. Group A had no cystoid spaces, Group B had intraretinal cystoid spaces within 3 millimeters, and Group C had within 6 millimeters from the fovea. They found that widely distributed intraretinal cystoid spaces were associated with poor visual acuity. Govito in 2017 coined the term ectopic inner foveal layers, which was defined as presence of continuous hyporeflective or hyperreflective bands extending from inner nuclear layer and inner plexiform layer across the foveal region. You can see that normally these layers should stop here, but here there is inner nuclear layer and inner plexiform layer is crossing the foveal area. Epiretinal membranes were classified in 4 stages by Govito. Stage 1 is a mild epiretinal membrane in which there is normal foveal depression and normal retinal layers. Group stage 2 had loss of foveal depression, but retina was still relatively normal. Stage 3 had all the findings of stage 2, and there was this presence of ectopic inner foveal layer crossing the foveal zone. Stage 4 was more advanced stage where there was disorganization of the retinal structure as well as presence of ectopic inner foveal layers. Govito stages 1 to 4 through 4 were associated with poor baseline visual acuity through progressive stages. Several studies looked at the prognostic significance of ectopic inner foveal layers. Gonzalez and colleagues did a study on 88 pseudophakic eyes with idiopathic epiretinal membranes who underwent surgery. Preoperatively, 24 eyes were stage 2, 45 eyes were stage 3, and 19 eyes were stage 4. Postoperatively, at 12 months, about 92% of the stage 2 eyes and 42% of stage 3 eyes and only 5% of the stage 4 eyes achieved a visual acuity of 20/40. In terms of anatomical improvement, more than 70% of the stage 2 eyes improved to stage 1, whereas majority of the stage 3 eyes, more than 91% eyes remained in stage 3 and only a small fraction improved to a better stage. All of stage 4 eyes improved to stage 3 but continue to have ectopic inner foveal layers. The result of this study showed that not only visual outcomes were better when the surgery was performed on stage 2 eyes, but an improvement in staging was also more likely to occur in stage 2 when compared to stage 3 and 4. The study concluded that EFIL formation should be strongly taken into consideration in decision process for epiretinal membrane surgery. Dina and colleagues looked at disorganization of inner retinal layers as another possible prognostic marker for epiretinal membrane. In this study, the boundaries at the outer and inner margin of inner nuclear layers were looked at, specifically the horizontal boundaries between ganglion cell, inner plexiform layer complex, and inner nuclear layer, and between inner nuclear and outer plexiform layer in center 200 micron was evaluated for presence of distinguishability and regularity. A score of 0 to 1 was assigned based on distinguishability and regularity of each layer, and the grade of no drill, mild drill, or severe drill was given based on the cumulative score of 0 to 4. In the top row, there is a case with epiretinal membrane with no drill. Both boundaries at either end of inner nuclear layer are normal. Here, there is a case of epiretinal membrane with the mild drill. You can see the inner boundaries are indistinguishable and irregular, whereas the outer boundaries are relatively intact. In patients with severe drill, all at both ends of inner nuclear layer, these boundaries are indistinguishable and irregular. In this study of 90 eyes, patients without and with mild drill gained a mean of 3 lines of vision 12 months after surgery, in contrast to only 1 line of gain in patients with severe drill. Ellipsoid zone, which is also known as ISOS junction, is a mitochondrial-rich hyperreflective band in the outer retina, and several studies have found a statistically significant worse visual prognosis, worse postoperative visual acuity in patients with preoperative disruption of ellipsoid zone on OCT. Interdigitation zone, which is also known as cone outer segment tips line, is a hyperreflective band in the outer retina between ellipsoid zone and RPE. Like ellipsoid zone, disruption of the interdigitation zone is considered indicative of photoreceptor damage, but this can generally improve after surgery. Presence and increasing length of preoperative interdigitation zone disruption has been associated with worse postoperative best corrected vision. This is a representative case. There is a preoperative epiretinal membrane. Postoperatively, the vision improves from 20/80 to 20/40. Initial pre-op OCT shows significant disorganization in the inner retina, and there is a large area of interdigitation zone which is disrupted between these yellow arrows. Postoperatively, at 12 months, there is improvement in the inner retina as well as much shorter length of interdigitation zone which is disrupted. Central bouquet is a subfoveal area of approximately 100 micron, which consists of dense accumulation of cones and Mueller cells. Govito and colleagues divided central bouquet abnormalities into three groups. There was a cotton ball sign, which is just a hyperreflective round area outside ellipsoid zone. Then there was a central pocket of subretinal fluid, and the third stage was central vitelliform lesion. They found that visual acuity was highest in association with cotton ball sign and lowest with acquired vitelliform lesion. Many times this cotton ball sign reverses after vitrectomy. So what is the most important biomarker, OCT biomarker? Based on the large review of 49 peer-reviewed articles by Rajan Singh, there was photoreceptor integrity, including both ellipsoid zone and interdigitation zone, is identified as most consistent marker for better post-operative best-corrected visual acuity. This review also suggested that EFIL-based ERM staging by Govito is an easy, fast, and reliable way of classifying epiretinal membrane based on their OCT features, and this provides an evidence-based prognostic indicator of post-operative best-corrected vision. Quickly, we'll look at a couple of cases. This is a patient I saw back in 2021. Reasonably good vision, significant epiretinal membrane with some EFILs, and outer retina is somewhat intact. Patient did not opt to have surgery, and you can see in 2025 a slightly more significant epiretinal membrane. There's a lot of disorganization of the inner retina, presence of foveal, presence of cystoid macular edema, and outer retina is also affected. So based on our discussion, this patient may not get as much benefit at this stage. Another patient, which has a younger patient with 20/50 vision, had an epiretinal membrane, cystoid macular edema, and mild vitreous hemorrhage. This epiretinal membrane was secondary to a peripheral neovascularization due to a sickle cell disease. Patient did not want to have sector laser treatment, and anti-VEGF was given. Unfortunately, comes back about 6 weeks later with significantly reduced vision and contraction of the posterior hyaloid with crunch phenomena, disorganization within the retina, and outer retina also has changes. Urgent transplant vitrectomy with ERM, ILM peel, and gas was done. And fortunately, 9 months later, patient has regained a lot of vision. And you can see, although there is some EFIL present, fovea starting to form. So this patient did really well. This case demonstrates that early intervention can have a much better vision and anatomical outcome, especially in younger patients. Thank you very much for your time and attention.
Thank you, Dr. Bilal, for your interesting cases regarding epiretinal membranes. Now I'd like to invite Dr. Isman Mahmood, who's come from UAE, and he'll be talking about an interesting case of laser-induced macular hemorrhage.
Thank you very much, Professor Huma. And good morning, everybody. Today, just a short case, a very interesting case I thought to share with my retinal colleagues. So this is a young Spanish guy who was 28, 29 years of age, had a sudden loss of vision while he was at a nightclub in Dubai. He noticed and he reported that there were laser show going on in the club, and there was a sudden spark in his eyes when the laser was pointed directly towards him. And since that point, he suddenly had a loss of vision. So when he reported, his vision was hand movements in the right eye, 6/6 in the left, and normal anterior segment. Intraocular pressure is normal. All the parameters of anterior segments were normal with clear vitreous, no sign of any vitreous hemorrhage. So this is the dilated fundus examination picture. You can see a big blob of blood present covering the macular area, especially the fovea. It is elevated, and the OCT scan shows the presence of sub-ILM thick opacity, obviously blood. So, for the sake of discussion, obviously we need to see what is the diagnosis, what do we do now, because he's a young guy and he's panicking, his vision has gone down. So what do we do? So before making any decisions, I think it is important that we classify, we identify the location, the exact location of the problem. Is it a pre-retinal subhyaloid bleed? Is it sub-ILM? Is it intraretinal? Obviously subretinal, sub-RPE or choroidal. So these are the most common locations anatomically we come across in these kind of things. So in this case, on the basis of the OCT scan and the clinical pictures, we thought it's a sub-ILM bleed, which was quite localized. The options in this situation is either to observe, just to watch, to see how things go. Is there a medical treatment? I'm not sure, but it can be considered in some studies. YAG laser posterior hyalodectomy, but it is again possibly uh, not for sub-ILM bleed or surgical intervention, as we know, vitrectomy and ILM peel, etc. So this is the first week after. So after a long discussion I had with him, I said, let's watch, and he was happy to wait, and we decided a timeline that maybe we'll probably go every visit and see how the things go. So is this the pointer here? So the first week, it's more or less the same. This area, so we'll closely watch as the blood start to gravitate and start to hemolyze. And this is the OCT picture, nothing much of a change. So in third week, you see there is a level coming up, which is sign that the clot is hemolyzing, and it's gravitating, and now we are achieving a level on the top. Again, you can see the height of ILM, sub-ILM bleed is getting less, which is a positive sign. Vision, although, remained the same. So as we kept going along, fourth week, more or less the same, but a little opening started to come up right in the middle. Again, OCT remains the same. By 6 weeks, it is really getting less, and again, the patient starting to improve some sort of vision and started to gain his confidence, because at that moment he was quite insistful of getting a vitrectomy done. And now you can see in the OCT, it is getting much flatter as the blood is absorbing. And this is 10 weeks. As you can see, it is completely absorbed. So no intervention, no medical treatment, nothing, is completely absorbed. And the OCT scan also shows that it has complete resolution there. So at the end point, we had a complete resolution, nearly full visual recovery, slight difference in color vision, but more or less nearly complete recovery. So what is the take home message in this thing? Although these kind of bleeds can be quite dramatic looking, and the loss of vision can be quite disturbing to the patient, but once we identify the presence and location of the bleed, then simple no treatment can work sometimes, and probably most of the times. So this kind of localized bleed can be safely observed, in my opinion. 3 months, I think, should be a cutoff point, as long as patient has good vision in the other eye and able to manage day-to-day activities. The intervention, either with laser or surgical, only to be considered under following circumstances, in my view. If the patient has decreased vision in the other eye, or no clinically observable improvement in vision or hemolysis in the clot, YAG laser posterior hyalodectomy, I think it should be reserved only for pre-retinal hemorrhages. It is too dangerous to attempt. I think it probably be unsuccessful. I've never tried it for sub-ILM bleed, because I think it's a little tougher membrane to break through. Vitrectomy and ILM removal is for sub-ILM bleed, which, especially in this case, if it did not improve over a period of time, then yes, finally you can proceed with the vitrectomy, induction of PVD, ILM peeling as standard, and you can drain the blood from there. So thank you very much for your attention. It's a short case, but Bilal wanted.
China made, and they don't have the actual, I mean, they may be more powerful than what is listed. So I had actually personally repaired maybe 2-3 cases of laser induced macular holes. So my question was also, did you think that a fluorescein angiogram should be done just to make sure that there is nothing I mean, although it will be blocked, but I mean, was this truly related to laser, or was it just, I mean, he thought that it was laser or just a Valsalva?
Well, I don't think it was. I mean, it looks like Valsalva. If the patient has not was definite about the point and moment He thought the laser light just hit his eye and there was a flash in his view. Uh, he did not have any severe cough or anything like that, or any. And the fluorescein angiogram, as you rightly said, would not have given us any further information because it would block. It would not tell from where the bleed came from. And it has been reported in literature that with the laser, especially in nightclubs or places where these strong lasers, apparently, if the laser get focused right at the fovea, sometimes they have some sort of disruption, which can cause because of the power of the laser itself. So I think it is even the toy guns. I think it is very imperative and important to realize that if they're able to get it focused, the intensity of the energy at that focal point can really cause us. It is very difficult. It's one in a million chance, I think. But if it is there, it can cause damage. So one has to be careful.
Because I mean, one thing that is a foveal avascular zone. So blood should not generally happen. It should be a hole in the fovea there. But so that's kind of interesting. But I mean, I have seen cases of Terson syndrome where there's very similar situation where patients with some sort of intracranial pathology, patients will complain of poor vision, and usually in there was a prisoner who they thought was faking, and actually was a significant ILM bleed, sub-ILM bleed. So it's very interesting. I had never heard of.
Obviously, is a slightly different category, but anyways, it's all hypothetical. It is all circumstantial. That we thought it is probably the laser induced, and it settled without any intervention. Thank you very much.
Usman, two things. Firstly, I mean, as far as the cause of the hemorrhage, I've seen a couple of cases. I definitely remember one lady who went for a facial laser and she wasn't wearing any protective glasses, and she actually presented with a retinal tear and vitreous hemorrhage with following that laser. She said, during the laser, I've noticed that there's something happened, and I developed this sudden floater, and basically she had a vitreous hemorrhage, not enough to stop me from doing the laser, so I was able to laser the tear, but there was clear cut skin laser. But I'm telling you, she came right from the sort of.
I think she might have misfired, or it has gone into the eye. Definitely, because
the other thing is, what about the toxicity of the blood sitting on the fovea?
I think that's a very, very good point, and that every time I saw this guy, this point came into discussion, and you're absolutely perfectly right that we're always. And I told him at the same time that there is a chance that if the blood even gets absorbed, you might will be left with some sort of deficit, and it is a known fact that there can be. So it was just something where, because luckily it absorbed within 6 weeks. If it had gone on for another 2 weeks, I would have certainly intervened to remove.
Also, I think local toxicity of the blood.
Absolutely, you're right.
It's concerning.
Which one? No, it's the cut is not right. The cut is not right. The patient was 6x6. There was no ERM. I think that's the only section I had. The cut is different, so it's not. So he had no ERM, and the vision was completely. And he's a young guy, 28 years of age. You don't expect the ERM to develop in that. But anyways, there was no ERM. Thank you very much.
Thank you so much, Usman. You have another presentation.
So basically, now we were talking from the laser-induced injury. Now this is a full-blown injury, traumatic giant retinal tear. Basically, this is a young female. She was involved in a car accident, and the airbags blew and opened up on her face. Although she was wearing seat belt, and there was no significant physical harm, except after a few days she left. She felt that the vision in the eye has gone down with some flashes and floaters in the left eye. No particular ophthalmic history except that she was myope -5. So the clinical findings: significant loss of vision in the left eye, normal tear segment, extensive tobacco dusting in the vitreous with large operculum, PVD, and a giant retinal tear from 1 o'clock position till 5 o'clock, with posterior edge rolling over the macula. And she also had multiple horseshoe tears in the supranasal and supratemporal quadrant. So the plan was obviously to proceed for vitrectomy, endolaser, 5,000 centistroke silicone oil under GA. There are a lot of school debates about the buckling or using maybe gases, but in my hands, this is my standard practice. I don't use buckles. So the challenges in this situation is a large folded giant retinal tear with multiple small retinal tears. There was a clear lens, so obviously we wanted to save it, and she was high myope. All the risks attached with a high myopic patient and so going into surgery. So the aim of the surgery was to unfold the giant retinal tear, to treat the other breaks, to spare the crystalline lens, and to reattach the retina without scleral buckling. So it's a small video. There are two videos joined together. One was with the surgery itself and then removal of the oil. So you can see big giant retinal tear. So I normally start with stabilizing of the posterior pole after a little bit of a core vitrectomy, so that to prevent the further folding. So once the posterior pole is stabilized, then I finish the core vitrectomy, and special care is taken for the anterior flap removal. That's the key in giant retinal tears as compared to normal retinal detachments, that we have to remove the anterior flap as much as possible to prevent PVR and all that. So once it is done, the heavy liquid is used to unfold the giant retinal tear, and it had a double rolling. One was the full tear was rolled, and also one of the edges were rolled inwards. So that challenge can be met with either the diamond dusted scraper. You can use it physically, unroll it, or you can use the flute needle to slightly grasp it and unroll it. So once it was completely done, then certainly it's important that you treat the rest of the breaks. And in this case, she had multiple breaks, and the retina was completely attached with the heavy liquid. So it's always important that the focus is not only to the giant retinal tear, but also the other breaks we need to address. Then coming to the laser, 360-degree endo laser involving the area of detachment, 3 continuous rows, gentle white burn. You don't want to overcook the retina because it can always cut through once you remove the silicone oil, and it can induce PVR as well. So this is again step one has to be taken carefully. Then finally, doing the cryo to the horns. I always cryo the edges of the giant retinal tear because I feel that gives me more strength. Then coming to the air fluid exchange, some people go with the direct PFCL oil exchange. I've done the other way. I always do the air fluid exchange first. It has to be slow, gentle, and with patience to avoid the slipping. The important thing is you remove all the fluid, all the saline before you start the exchange. And once the exchange starts, you keep your flute needle right at the edge until the perfluorocarbon bubble goes down. And now it's a video 3 months after when I start to plan the removal of the oil. The retina was completely attached, and then the silicone oil was removed successfully with the attached retina at the end. So what is the pearls in this situation? The surgical steps were the quick stabilization of the posterior pole with a bubble of heavy liquid after core vitrectomy. Meticulous internal search. I think sometimes as a surgeon, we are mainly focusing on the main pathology, and we forget that in injuries, traumas, you can have other sides also getting affected. Thorough peripheral shaving with indentation, complete removal of anterior retinal flap, the use of heavy liquid to unfold the retina and the giant retinal tear, and it can be assisted with Tano dusted scraper to unroll the small edges. 360 endo laser, I think, is the key with extra care while applying to the edges of the tear. Cryo application to the horns of the joint retinal tear. And then when we start the air fluid exchange, my little take home tip is to tilt the eye as much as possible so that you can extract the remaining fluid from under the retina. Slow air fluid exchange, so get your parameters and the FAX down to 20 or 25 because you want to have slow air fluid exchange to prevent the slippage, and to remove all the fluid before pumping air. This is again the key because if the fluid is remain there, the air can push it under the retina and it can cause the slippage. The fluid needle to be kept at the edge of the heavy liquid bubble until the bubble passes the posterior edge of the break to prevent the slip. So complete removal of heavy liquid. The choice of tamponade depends on the experience. I normally stand as a standard use 5000 centistoke. I don't feel a need of scleral buckling. If I've done a thorough vitrectomy, good peripheral shaving, then there is no need for the scleral buckling. And most importantly is the examination to the other eye, because sometimes they would also need some laser in case there are some weaknesses. Thank you very much. Sorry? Absolutely.
Or you're using active extrusion. So with active extrusion, you want to stay and constantly go through the whole edge of the tear to make sure that you absorb any fluid from the edges before the air crosses there, so that it's kind of flat. And if you have a chandelier in there, you can actually depress a little bit to make sure that you can suck extra fluid there. I don't do direct exchange. The reason being, PFO is very likely to be some PFO can be left during this process. So, and in majority of the times, as you know, the key is, as you said, PFO, and which kind of basically makes your surgery relatively easy. And then the last step of, so it's a great case.
No, thank you very much. I think the key in the air fluid exchange, I mean, I do a passive exchange and I go very slow. So first step I do is I just turn the eye towards myself and try to get all the fluid under the lens. It's easier if it is pseudophakic, but it is phakic, it is a little tricky to remove all the fluid before I push the button for FAX. So once I'm completely assured that I've removed all fluid and just what is left is the heavy liquid, and then the air start coming in, and then I tilt my eye towards the break and keep the needle there until the PFCL bubble goes beyond the edges, and then I'm happy and I'm safe that we can fluid the rest. But that's the key. Thank you.
I'd like to invite Professor Khalid Waheed, who will be showing us an interesting macular surgery case of how to remove the submacular bands.
My original presentation had some technical issues, so we will have to do with the video. So just taking you through the history of this patient, this is a case of uveal effusion syndrome, a 30-year-old lady who initially presented to me with subacute visual loss, and on examination she had bullous exudative retinal detachment involving both eyes, asymmetric, the right eye being more involved than the left, and the vision had dropped in her more affected eye to 6/60, 636, 660. So I gave her an initial course of systemic steroids to see how she responds to the treatment. She comes back 2 weeks later with a very different picture. The extent of exudative detachment, the bullous part was much less, but she presented with 5 rings of subretinal fibrosis in her retina, and one massive ring which was involving the disc and the macula. So when we are dealing with subretinal bands, I think what is important is there are various ways of skinning the cat. The band which involves the macula, you have to be very, very careful with. Now, there are various tricks, there are ways of removing them. Obviously, for each band, you have to first of all pick up where the epicenter of the band is, and then you have to do a retinotomy. And the place where you select the point of retinotomy, especially if the band is passing right through the macula, has to be very carefully gauged and selected. If the subretinal band is a simple band, you can pluck it out. So you can simply pluck it out. But there are bands where you have stellate arrangements. So again, you can do a diathermy and pluck these out. But the bands that we are dealing with here in this particular case are extending from the disc and running onto the macula. So here you see it's involving the macula, and it's actually a complete circle. So how do we deal with such a band? So I thought that we should do a retinotomy at the top and the bottom end of the band, and you have to use bi-manual technique. Some people call it a spaghetti technique, where you now this particular, I had to make 5 retinotomies to remove these bands. You have to be very careful. You have to diathermize all the areas properly before you start cutting these bands. Otherwise, they can bleed and cause massive subretinal hemorrhage. So basically, two retinotomies were made for this particular band. One just supranasal to the disc, and the other one was infranasal to the disc. You also have to see how much strength that band has. Sometimes you can just amputate it. You don't have to remove the whole thing. Amputate it, and take off its strength. But this particular band had to be removed. Now it's quite tough, and when you come across a band of this strength, you have to use bi-manual technique to remove it. So initially you hold the band with one forceps and try to disengage it, and then pull in the direction, anteroposterior direction. Once it is removed, you can obviously go back to air fluid exchange, laser your retinotomies, and do a air silicone oil exchange. Thank you. Mic dena yaar. Yes. Yes. I think it's like a pajama string. If you cut it and you feel that the problem is resolved, basically it's the traction which we want to release.
So you can leave the part which is
You can leave it
because it is elastic sort of, and it goes, I mean, towards the macula.
Also depends upon the location. Now,
Yes.
if it is submacular, then I think it's a good idea to do a retinotomy at the other end and pull it out from the other end.
Okay.
So there's also a technique called spaghetti techniques where you use a light pipe and you actually curl the band around it and then pull it. So that's a bimanual technique. So you curl the initial band around it, and there's less chance of it springing back.
Okay.
So उसको ऐसे फोर्सेप से पकड़ के लाइट पाइप के साथ ऐसे करके इसको ऐसे खींचे और साथ फोर्सेप से पुल करें.
Second thing is, if you've got those bands very away from the macula, extramacular, can you leave them as
Yes,
such?
you can leave it.
They will not cause RD or something like
It is like delamination. You segmentation. You have segmented it, so it will.
No. If you don't do anything for them
For the peripheral
for the
ones,
peripheral bands.
I would leave them.
Okay.
I would leave them. Yeah. Any more questions?
Khalid, for showing us an interesting case, I'd like to invite Muhammad Hassan Ali, who will be presenting on the inverted ILM flap technique, advancing success rates in large macular hole repair.
Bismillah ar-Rahman ar-Rahim. A very good morning to all of you, ladies and gentlemen. I think our seniors have shown very complex cases, like just one shown by Dr. Khalid Wahid. My presentation is relatively simple. So I'm going to talk about, I'm Dr. Muhammad Hassan Ali. I'm currently working as an assistant professor of ophthalmology at Allama Iqbal Medical College, Jinnah Hospital, Lahore. I'm going to talk about inverted flap technique for large macular holes. Now, so whenever we are doing an OCT of a patient with macular hole, you have to measure various indices and various diameters. Like, for example, is basal hole diameter, minimum linear diameter, and hole height. If the macular hole is greater than 400 microns in any of these diameters, we declare it as a large macular hole. Now, what is the rationale for ILM peeling during macular surgery? So, ILM has been implicated in different kinds of vitreomacular surface disorders. And its removal has shown, number one, to remove the residual traction over the surface of the macula. Secondly, the removal of ILM basically removes the potential scaffold for formation of a subsequent ERM on the surface of the macula. And lastly, if we remove the ILM and we put it as a scaffold on the surface of the macular hole, that can act as a scaffold for closure of the macular hole. Now, various studies have compared the peeling of ILM versus non-peeling in patients of macular hole. And one study reported 93% success rate with ILM peel versus almost 80% in the non-peel eyes. Similarly, ILM peeling has shown to have significantly reasonable outcomes in the vision and the anatomy of the macula in the restoration after macular hole surgery. It was almost 100% in the ILM peel group versus 82% in the non-ILM peeling group. Now, the thing is, the standard care today for macular hole is parsimony vitrectomy with ILM peel and with endotamponade gas with face down posture. But there are certain holes which still fail to cause despite ILM peeling, almost 20% of them that were published in a recent study. So that implies that ILM peeling alone may not be enough for large macular holes, and especially if the patient is suffering from chronic macular hole, you need to devise some other technique which can provide us better results. So, in 2010, Macula from Poland, they proposed a novel technique and they labeled it as inverted flap technique for large macular holes greater than 400 microns. And they reported 98% closure rate with inverted flap versus 88% in the non-inverted flap group. And the VN gain after this closure was significantly better as compared to the non-inverted flap. They propose that this inverted flap induces glial cell proliferation and fill the macular hole with proliferating cells. And now we know, after research, the basic science research, it has come to know that ILM functions as a scaffold for the proliferation and migration of Muller cells. And these Muller cells basically provide various kinds of neurotrophic factors, fibroblast growth factors that basically help in the macular hole closure. So now I'm going to show you a couple of videos in which how do we do this technique. So you start first of all doing PVD and you stain the ILM with brilliant blue G, and then you start lifting the flap. So first of all, you are trying, you have started doing the pinch and peel technique in the supranasal quadrant and gently removing the ILM in the circumferential manner. So while I was starting to learn this technique, initially the whole of the flap would come off, and you have to ensure that some part of it still stays along the macular hole margin. So in this patient, like for example, inferiorly the flap is still attached. You complete the peeling around first of all, and then you're doing still completing the ILM peel 360-degree around. And now when you're doing this fluid exchange, you basically, the flap is still left along the whole margin, and you're gently draining the fluid at a very low aspiration along the supranasal quadrant with the fovea, and then you do the gas exchange, and you can slightly maneuver this flap and close, apply that flap over surface of the macula, and then you can close the case under gas and advise the patient as a face down posture. So the key is to keep the aspiration as low as possible. So this was a preoperative picture of this patient, a large macular hole, and this was the closure that we achieved after performing this surgery. Now, in the initial days, I want to show another technique here. In initial days, I was struggling to keep that flap in place. So our supervisor taught us this technique also, that you can use basically PFCL over surface of the flap. I'm going to demonstrate here. So here I've started doing this peeling. This is circumferential 360-degree peeling of the ILM. And first of all, you have to create a flap. And once you have created that flap, so again 360-degree enlarging the peel. Now you have a flap 360-degree around that macular hole, and now once you are ready, for example, for the fluid exchange, you have to ensure that the flap stays there. So this technique basically proposes that you can apply a small bubble of PFCL over surface of the macular hole over the flap. So the flap will stay in place. So a small bubble has been applied, and now you can gently maneuver the flap along the margin of the macular hole and gently tuck it in over surface of the macular hole like this. So gently tucking in here, and then you see this is the PFCL bubble, and then you go for fluid exchange, and then you can gently remove this PFCL bubble, and the flap stays in place absolutely fine. So I think for the beginners, they can use this technique as well for stabilizing the flap over surface of the macular hole. So now we're doing this fluid exchange, and now this is the pictures of pre-op, big macular hole, and post-op the patient was able to achieve very good VN after 3 months. So to conclude, macular hole surgery, the standard of care is sparse vitrectomy with ILM peeling. And if you have larger holes greater than 400 microns, you need to devise a technique, inverted flap, or there are other techniques like temporal flap or free flap. You can use them to achieve better anatomical and visual outcomes. Thank you very much for your very patient listening and attention.
So yeah, that's the outline, how to define, identify submacular hemorrhages, what can be different causes, and how to manage it. So we know that submacular hemorrhage actually is a hemorrhage between your sensory retina and retinal pigment epithelial layer. And there are multiple variety of the causes. Important top of them usually is wet age-related macular degeneration-related polypoidal choroidovasculopathy. It can be even retinal arteriolar aneurysm. Myopia can also lead to submacular hemorrhage, trauma, or even macular neovascularization due to other causes, or rarely with the tumors as well. So if you look at the wet AMD, it's around 5.5 to 25 per million per year chances of developing submacular hemorrhage. And most of the time it happens in the cases where they have got the patchy treatment. So the treatment was given and then the treatment was stopped. So variety of the modalities that give us a clue about that. How does it? You can go for optical coherent stomograph. You can do OCT, and that can gives you idea about the location, what layers are involved, where exactly is there the hemorrhage there. And OCT angiograph also helps regarding the blood flow. You can get idea about that. So here are the few examples. You can see there is a large submacular hemorrhage there. That's another case. And even here, you can see when you do OCT, you can clearly hear the hemorrhage is there, but clearly you can see there is a subretinal hemorrhages, there is sub-RP hemorrhages, there is subretinal fluids. So all the things you can get a better idea about. So how does the visual loss happen in these cases? One thing is a barrier effect, because the nutrition gets disturbed and you can have the long-term damage to your photoreceptor, or even the tractional changes. What happens? Your photoreceptors get stretched and they get damaged, and there is a loss of the vision or toxic damage. Even the ferritin can lead to damage, and photoreceptors die. And overall, there can be scarring can develop, and irreversible damage can happen if you don't treat it. So, what's the natural history and prognosis? Typical outcome if untreated, it progress without intervention. Visual prognosis depends a lot on the size, that how big is the hemorrhage, how much the duration is there, and what exactly is the cause of that. Like wet AMD, if there is advanced damage due to macular neovascularization, it may be possible that the vision doesn't improve. So these are the poor prognostic factors. One thing I already mentioned, macular neovascularization. Other thing, very thick submacular hemorrhage. Macular degeneration due to wet, large submacular hemorrhage. And what are our treatment goals? We want to clear that blood. We want to minimize damage to the photoreceptors and preserve the vision. So deciding factors are, when we are dealing is, as already talked about, the hemorrhage size, that's the duration, patient age, overall health of the patient. And you, of course, you have to weigh to the patient's other risk factors. So what are the treatments available? One thing is that there is some macular hemorrhage. You just give anti-VEGF, treat the patient, and gradually it will go away. You can do pneumatic displacement. You can inject intravitreal air or gas that can displace it. You can do vitrectomy, either just a vitrectomy, you do it, you put the gas bubble, you try to displace it, or you do use the subretinal TPA. Or even previously, which was more popular, submacular surgery. Actually, you can give the large incision, you can remove that hemorrhage from that area. And it's been clearly shown from the animal studies that very quickly photoreceptors damage starts within 24 hours, and in 7 days, usually there is a significant damage. So we all know anti-VEGFs, they work by reducing the vascularization. So new vessels get regressed. These are the common agents. And smaller hemorrhages usually works very well. So that's one of my case. This patient was on treatment for anti-VEGF, but as we were prolonging, he came back. There was some macular hemorrhage, and here it does look like that. So there is subretinal hemorrhage large. There is RP hemorrhage. This patient had a very good vision in other eye. Patient decided that he would like to get observed. So we we switched them from Eylea to Vabysmo. We started over. So you can see that the hemorrhage is gone, but all that area, there is significant damage there, and you can clearly see here. So his vision, which used to be actually 6/18 before this hemorrhage, now after resolution, it just came to around 6/45. It didn't improve further. If you look at the background of TPA, Payman first used in 1991 in human subjects. So pneumatic displacement, I've already mentioned you about that. You can inject either air or gas. Positioning is very important, so it depends either your patient is going to position or not. Pneumatic displacement with or without TPA. So that's another approach that you are going to inject, and you can inject intravitreal TPA as well. So outcome is between 35 to 65% they show improvement. So that's important cartoon diagram. So whenever you're putting the gas bubble, positioning is really important. So if you look here there is a gas bubble there, but if patient is sitting upright, yes, with the gravity it will go, but it's not applying maximum force. However, if you ask the patient to look down, the gas bubble will put more impact, and that will bring it down further. So usually we recommend the posture is that sit, head nodding position is the better one. That helps to move it quickly. So TP assisted vitrectomy, how does that help? So you do actually vitrectomy and then you inject subretinal TPA, 12.5 microgram to 50 microgram in 0.1 mil, that dissolve the clot. Very highly successful. Even from the next day, you notice that the most of the blood will go away. Yes, of course, there are risks. Rebleeding risk can be there. You have to identify the area where you're going to inject. You don't want to go over the RPE areas. You have to select the area. So mostly we go to the retina where there is no bleed initially. You can lift it up and then you can inject further. And you can develop retinal tears or retinal detachment, but it's a 41 gauge needle. Usually no problem happens with that. So that's one of my initial one, then 23 gauge, that was from 2011 when I was in Scotland. So at that time, 23 gauge vitrectomy, even the cannula was not the finer one. At that time, it was a 38 gauge. So you can see the massive submacular hemorrhage, already vitrectomy is done. So I'm injecting the TPA, you can see the ballooning. You can go, not necessarily you go at one site, you can go to multiple, it doesn't induce. Once done that, fluid air exchange and 20% SF6 was placed in and patient did well. So that's another patient in which you can see there is vitreous hemorrhage as well, a breakthrough vitreous hemorrhage as well as large submacular hemorrhage. So 25 gauge vitrectomy is already done and I'm injecting the TPA and you can see that the fluid is going in and lifting it up. And once you're sure that all area is covered, you don't need to, the important thing is you want to inject amount to the certain extent. You don't want to induce a macular hole there, because if you inject too much fluid, hole can easily form and finish up case with the SF6. So if you look at the intravitreal TPA, gas tamponade versus vitrectomy subretinal TPA, in comparison, you may not notice much difference in the visual outcome as well as the central retinal thickness. Best-corrected visual acuity improved very quickly in cases in which there was vitrectomy done. So that's the other case. So now in this case, there are RP hemorrhages as well as subretinal hemorrhages. So that was 27 gauge vitrectomy, but the cannula actually goes through 25. So I put one trocar of 27 gauge. So important thing is that how much scarring is there. If there is a significant scarring in the center, you may not get much improvement in vision in such cases. But otherwise, it's a very safe procedure. You can inject, and I'll show you a few examples in which how the outcome came up. So what I do now is I inject some air as well besides. So initially I inject some air that helped to mobilize it and then some fluid. So that's one of my case who presented with a large submacular hemorrhage. Vision was counting finger, and you can see the massive, it was coming up to the fovea. So it was involving, it was temporal, but it was involving, and patient was really keen to get improved vision quickly. And previously, this was treatment naive patient. So here, you can see that I'm injecting air. So I've injected some air first. Some bubbles came up into the vitreous cavity as well while I was injecting. Once I've done that, then I'll go with the TPA injecting. So in the same syringe, I've got some air bubble and that. So you can see that it's like a bubble formed there, attachment, but it very quickly goes away. Next day, you won't see it, and most of the blood gets displaced inferiorly. So you can see that after 1 week, most of the blood is gone, and you can appreciate from here. So you know that there are pigment epithelial detachment areas, subretinal fluid is there, but mostly from the center, the fluid is gone, and the patient vision was improved to 6/9. Of course, we kept on intravitreal anti-VEGF treatment. So that's another patient. So there were at multiple areas the hemorrhage has happened. So you can see in central as well as on the side. From here, you can see there is a large submacular hemorrhage involving the fovea. So that again 27 gauge, I'm using 25 gauge trocar to inject. So I'm injecting air, that's gone in. And then I'm injecting the TPA. So important thing is that air, you don't want to inject too much air for that, because otherwise, and sometimes what happens, you have to select the site. So usually I go superiorly. If you go sometime inferiorly, then chances are that it will go further down. So that's the same patient. You can see that all hemorrhage is gone. Subretinal fluid is there. So we are giving the anti-VEGF. Submacular surgery, I think it was popular sometime, but because of the new treatment modalities and especially anti-VEGFs that come up, it's not much popular, and we know that the results wise that doesn't make much difference. Of course, in these patients, anti-VEGF treatment is the treatment of choice. In photodynamic therapy has role in certain cases, especially the polypoidal choroidal vasculopathy one. So here images shown hemorrhage on optos. Once it's resolved, how does it look like? So what would be the recommendations? I think if it's a smaller submacular hemorrhage, you don't need to go for invasive procedure like vitrectomy, subretinal TPA, or intravitreal TPA. So you can just give the anti-VEGFs. Medium-sized or large-sized hemorrhages, yes, it's a very good option. And if I look at the patients I have done, no retinal detachment so far. So sometimes people think about that you're creating hole. So it's so tiny hole, it doesn't cause any problem. So it's very important to identify submacular hemorrhage, and you need to identify the cause, because if it is due to wet macular degeneration, you need to treat the patient later as well. And if you're deciding to go ahead, it's better to go earlier instead of waiting. Thank you very much.
Thank you, Professor Amir, for such an interesting talk. I'd like, due to the shortage of time, we'll not be taking any questions at the moment. So I would like to invite Hafiz Atikur Rahman.
Until very recently, TPA was not drape approved, I think, in Pakistan until last year. I think it just recently became available. How is the availability of 41 gauge cannula?
It is available from Med1. There is a company, I think they have got now, they distribute in Pakistan as well. I think other Optimed, they are dealing with it. So yeah, we can get it. But usually I was getting from there. TPA, I don't think drape approved Rasi, because we were having for a long time. But we were in Shifa, we were using it for a long time. I don't know how, okay, it's approved, but we were still using for stroke patients. So in Shifa, we have got like in our emergency, if the patients come with a stroke, immediately we treat it. Bilal, sorry, your question, yeah, Med1 I have already talked about. So it's the cannula is available. It's a 41 gauge, and it's the company is known as a Med1. It's now distributed is in Pakistan as well, so you can. I have to be honest, I haven't done that, but yes. It's easier. You can use that, and you can even some people combine it with a pneumatic displacement as well, inject the gas as well as TPA intravitreal.
So I'm actually using TPA for the last 1 year, and now I'm using the Manchester protocol. I think that's what they've authored that. So for them, first you have to give intravitreal. If that doesn't work, then you go inside. So I'm just following that protocol now. And
it's a very costly TPA. I don't know 65.
Oh, it is 65,000 rupees. So there are 3 TPAs available. So recently, because I started acquiring it, so the cheapest is 65,000, and then you have one injection for 150,000.
Yeah, we're getting that one.
Yeah, and the most expensive one, which is available at Hamidati pharmacy, that's for 295, and it's a 50 ml vial. So you just need 0.05.
Unfortunately, you need, but all vial goes away. Actually,
you need to throw it away. Yeah, unfortunately.
Patient's cost is because you can't.
Or you can like liaise with the neuro people. They might have some left on that day, maybe. Yeah.
And your patients mostly they were AMD related hemorrhages, or they were Valsalva. What type of patient they were?
Which one you're asking, Qasim or okay, Qasim?
So age-related macular degeneration and people on dual anticoagulant. So they are the major chunk of the patients.
Mine were.
It is in my hand.
Yeah, mine were macular degeneration related, but yes, you can use in other causes as well. Like I have reviewed one of the series in which they use for trauma cases, some macular hemorrhages, and when there is no choroidal rupture involving the fovea, it's a good results. You can
honestly up till now, at least for me, patients with PEDs and hemorrhagic PEDs. And a lot of hemorrhage, you can see the picture. We were dealing mostly with anti-VEGFs. So now we have an option of, giving them intravitreal TPA as well. So should we combine it with them, or only TPA, or both TPA and anti-VEGF?
No, anti-VEGF needs to be given. If it's a cause you need to treat. So if you're giving intravitreal, yes, you can give.
So
you can give it.
give intravitreal TPA for the hemorrhage to resolve in few days afterwards? Maybe.
One thing you can do is that if you want to have a pneumatic displacement as well as intravitreal TPA, you can inject that, and after some days you can go for anti-VEGF. Like in these cases, even if I do surgery, in some cases I do inject at the same time. Sometimes not necessarily after 1 week. I'll inject.
Actually, this pneumatic displacement thing, it could be very tricky in cases of, when you're not doing a vitrectomy, sometimes it can cause vitreous separation and vitreous PVR, very strong reaction, isn't it? Or you don't have any experience such something like that?
Not problem at all. So, as I told that I have done around maybe 12, 13 cases, not a single even detachment issue or any problem.
So it was air, not gas.
Yes.
One quick question. Many times, you have very neat and clean pictures, but many times these patients will have a breakthrough hemorrhage in vitreous cavity.
Yes.
So one has to be very careful doing like a B scan. You can see that subretinal hemorrhage. So if you have a large amount of intravitreal hemorrhage, and then you have like an area which is almost looks like something is pushing it upwards. So because if you wait for the like a vitreous hemorrhage to clear, you may sort of lose that window of intervention. So, have you seen breakthrough hemorrhages or?
Yeah, it does happen. In one case I've shown there was more because at the surgery I have cleared in the front. So yes, you can. So in those cases, it's really important you do want to do B scan, and sometimes they can have even macular as well as extramacular neovascularization as well, and that can lead to the bleed. So you can see the bleeding there as well.
Very nice.
Well, I didn't use for suprachoroidal one. I haven't used, but yes, that's one of the approach. You can liquefy it because as we know that usually in suprachoroidal we wait for some time to get liquefied. But if you want to intervene earlier, yes, that's an option. You can inject and it lyses the blood very quickly and you can go earlier. But I don't have my experience. I think somebody wants to ask her.
Going back to your last what we talked about with the TPA gas, I'm assuming you're using 100% gas.
You mean when
and is it C3F8?
No vitrectomy, just you're injecting.
Without vitrectomy, when you do TPA intravitreal.
After vitrectomy, you mean during vitrectomy, yeah?
No, without.
Vitrectomy. No,
without.
Yes, then you basically use a small bubble. Of 100.
Of 100%. Is it usually C3F8 or what do you?
Sorry.
Which gas do you prefer?
Well, I didn't use myself, but you can. It's like the same as you do for pneumatic retinopexy, as you do in the same way. So it depends what gas C3F8 you're using or C2F6 gas is using. Okay. So I think it's if I remember correctly, C3F8 it's around 0.2, 0.3, and for SF6 it's more point.
Thank you, everyone. That was a very well presented spectrum of cases. Now we'll start off with discussions and an analysis of the techniques of all of them. Starting with Dr. Bilal's presentations about epiretinal membranes. Now, we have to differentiate between different types of epiretinal membranes. When you look at the epiretinal membrane, clinically, you have a certain idea of how adherent it is to the underlying retina and if it's affecting the internal limiting membrane or the underlying retina. If it's loosely adherent, it's very simple to peel it off. If it's slightly more adherent, it has septa which are attached either to the ILM and sometimes even to the sub-ILM structures. So for those, the best thing is to apply some traction, peel off the loosely attached ERM and just keep the traction on till the septa slowly tend to loosen up and then separate. So that's the second type of ERM. The third one, which causes scrunching of the retina, which causes distortion of the retinal internal layers. So that's a more difficult one. And I'd like all the experts here to give their opinions on this third type of epiretinal membrane, which even though you've removed, it will still leave some residual convolutions and corrugations on the surface of the retina. And it will also cause some loss of the nerve fibers, and over the macula, it can cause some loss of visual areas and leave some visual deficits, some small spots. So I'd like all of you, all the speakers here, all the experts to comment on that.
So for all epiretinal membrane cases, you want to remove ILM unless proven otherwise. So if you remove ILM, basically it gives you a tissue which, any residual patches of residual epiretinal membranes. So many people will separate the main bulk of epiretinal membrane, then they stain again, and then we start outside the visual limits of your epiretinal membrane, start peeling the ILM towards the middle, and you will get rid of any tissue which is...
That is a school of thought that is not accepted by all the experts. That for an ERM, you have to remove the ILM as well.
Otherwise, the chances of recurrence are pretty significant.
Even though there's no trauma, there's no inciting stimulus, because this is a response, the epiretinal membrane is a response to an initial trauma, an inflammation, an injury. So if that stimulus has been removed, why should there be another one? It doesn't follow that there should always be another one, always be a recurrence.
So I'm sorry. So basically, basic pathophysiology is a small break in ILM. When you're peeling the ERM, you will induce teeny tiny micro breaks in ILM. So there can be a recurrence from that break. So original mechanism may not involve a break in the ILM, but there will be inadvertently some small break in ILM which will lead to a second epiretinal membrane formation.
Yes, that's the septa that I was referring to. Anyone else? Usman, Amir, Kashif, Qasim, would you like to comment?
Same, I would be, usually I would be removing in ERM cases part of ILM as well, but I would sometimes those very, very adherent membranes, I would like to leave them as such, even at the cost of some loss in vision, because trying to going after them, I've seen more trauma to the retina, to the macula actually.
Usman, what do you say?
To see if there is any residual membrane, but going back, I think the important part is that we need to treat the patient, not the scan.
Well, let me take you back to the first oath that we take as doctors. Primum non nocere. First, do no harm. So just because you can, do you think you should always peel or do more? Do you need to do more than you require? There's a school of thought which is less is more. So for an ERM, should you always peel an ILM? Should you always induce more trauma? What do you think? Amit? The house is open for discussion. I'm just generating discussion here, getting the opinions of the presenters and the experts.
I think just peeling the ERM is fine, and I don't necessarily always peel ILM unless there is some. Sometimes the traction is such, you see it on the especially VMT related ERMs, when there is a traction at the macular area, and you feel that when you're peeling the ERM, there is a chance that they might have created a micro hole or something. So only in that case, I will go back and then do an ILM peel and put the gas in. Otherwise, normally if the ERM is being removed easily, then I don't go for ILM peel.
Thank you.
ERM is quite tricky one. Whenever you are dealing with it, sometimes you just strain it and you think that it's all removed. But when you restain, you realize that there are further layers of that. So in these cases, usually I put the dye at least 2 times to make sure that I have removed the epiretinal membrane completely. And then if possible, in most of cases, I would try to remove the ILM. But as we were talking, not necessarily if you are feeling all right that ERM is completely removed, there are no remnants there, you may leave it. So it's very difficult. There won't be any hard and fast rule.
And we didn't talk about the vision, Dr. Bilal and Qasim. Would you care to share your views on how much vision and how much metamorphopsia would tempt you to go for surgery, and how long would you wait till you intervened?
So for ERM, my thing is metamorphopsia. I'll give the arm's length to the patient. If he claims he's got significant visual distortion, I would go for the ERM. And I always, with ERM, I always peel ILM as well. So for macular holes, we always peel ILM. And we get brilliant results after doing that.
Macular hole is different.
So for there are so many ERMs which lead to macular holes as well. So whenever you're peeling, I always do double peel, double staining. I always do that just to be sure. So even for my diabetic vitrectomies, my aim is I have to, if there's a retraction, I always do ILM peel for them as well, and that gives me very good anatomical results.
There are always pros and cons, and this is a long-standing debate.
And for any vision less than N8 on 612 and metamorphopsia, if clinically metamorphopsia, you have to do it. That's my type.
So in the old times, maybe 10 years ago, the cutoff was 2070 or worse in USA. Now it has shifted downwards to maybe 2030, 2040 if patient is symptomatic, because instrumentation is so good these days, the chances of complications are relatively rare. So people are doing more and more. And I presented that, if you leave the epiretinal membrane in stage 3 for long, you may not recover everything back. So if you decide to intervene, then it should be rather soon than later. So intervention has kind of the bar has been kind of lowered significantly in last 5
years.
years.
It's interesting that you should mention that, because while I was working in the NHS and training there, I used to go every year to some of the US centers and observe as a visiting fellow there. And when I used to come back, I used to discuss with my mentors and my teachers, and many a time it turned out that the US considerations were driven by Medicare, and they weren't specifically based on technical or professional considerations. I'm not saying anything against that, but there are some considerations which are Medicare driven. So that could be one of them.
But you remember that these all guidelines are also made by professionals, experts. Any input to Medicare would be not just a layman. It would be probably a group of retina specialists who think based on their experience that what should be appropriate.
Of course, the experiences in the NHS are driven by different criteria. Okay. So
the vision is very tricky, especially the practice in our country. I would say 618 is the cutoff, but honestly, I've never done it at 618 because afterwards, jo sunna padta hai na. So in my opinion, it should be something like 624 or 660, and the patient should earn it. He should be the one who is going to say to you कि जी मुझे तो बहुत तकलीफ है और मैंने ये करवानी है. At 618 वैसे तो value है मगर I'm not following that.
Thank you. So I'm told I'm running out of time. So we'll leave. Thank you.